everyone. My name is Sabrina Corlette. I'm a research professor and co-director of the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. I will be your moderator today as we delve into what's behind the corporate transformation of healthcare. For those of you not familiar with our center, next slide, please. We are a team of national experts on health coverage and healthcare markets. We study the interplay of federal and state laws and policies that affect how people access and use healthcare services. We publish numerous research studies and reports, and we also provide technical assistance to state and federal officials. Before we begin, I want to thank the sponsors of today's event, Arnold Ventures, and go over a few quick logistics. First, this webinar is being recorded. Everyone will receive an email early next week with a link to the recording. We will also post the recording to our website. Second, we welcome you to use the chat to introduce yourselves, share reactions, and connect with one another. If you have any technical issues, please drop those into the chat as well, and our producer, Nikita Bianula, will do her best to help you. Finally, this is a discussion, and while I will be asking our guests some questions of my own, we hope that you will be submitting questions for our speakers as well. You can do that by dropping questions into the Q&A box at the bottom of your screen at any time during the webinar, and we will do our very best to respond to as many questions as we can. All right, now it is my great pleasure to introduce what I think of as like a murderer's row of health policy experts and market analysts. These truly are superstars when it comes to healthcare policy. So we are joined by my colleague, Linda Blumberg, who is a research professor at the Center on Health Insurance Reforms and with the Urban Institute. Zack Cooper is Associate Professor of Public Health and the Associate Professor of Economics at the Yale School of Public Health. Stephen Parente is Professor of Finance and the Minnesota Insurance Industry Chair of Health Finance at the University of Minnesota's Carlson School of Management. And lastly, Zirui Song is Associate Professor of Healthcare Policy at Harvard Medical School. So what do we mean when we talk about the corporate transformation of healthcare? Because being a corporation by itself isn't necessarily a bad thing. So it's important to be clear on what we mean. What we're talking about here today is the consolidation of previously independent actors in the healthcare market into vertically integrated and horizontally integrated business structures that have centralized corporate decision-making rather than local autonomy. In the first webinar in our three-part webinar series, we heard how deeply patients, physicians, and other clinicians are being impacted by the corporate takeover of healthcare. And you can watch the recording of that first webinar by clicking on the link that we're putting in the chat. But the corporate takeover of healthcare really didn't happen overnight. Over decades, we have seen payers and health systems transform into healthcare giants as they buy up the competition and use their market clout to drive up prices. Meanwhile, patient care has not improved, and research suggests it can actually get worse after a corporate acquisition. So how did we get here, and what is coming next? This is what we hope to shed light on today with the help of our speakers. And to learn more about how corporatization might be impacting the healthcare market in your own community, please check out our center's latest resource, which we're dropping into the chat right now. All right, I'm going to kick things off by asking our speakers a few questions, and then we'll open it up to the audience. And just a reminder, if you have a question, please put that in the Q&A box at the bottom of your screen. So let's dive in. The corporate transformation of healthcare shows no sign of slowing down. In fact, it seems to be speeding up with new acquisitions and mergers being announced at a dizzying pace. And private equity has become a fast growing player in this space. So I'm going to start with just a general question for each of our speakers and have you each answer in turn. So one is, why are all these transactions so rampant in healthcare right now? What is driving the trend? And what are the trade-offs? And I'll start with you, Linda, if I could.
Sure. So when we first started to see hospital mergers going on in the 1990s in a significant way, the Department of Justice had a very hard time, it seems, convincing judges that these kinds of mergers required intervention. The judges seemed to be quite skeptical that entities like hospitals that had been serving the public for many years, very mission-driven in a lot of ways, that they would behave like traditional economic monopolies, that they'd increase prices, they'd make entry into the market difficult. And this was particularly true when they were looking at mergers among nonprofit hospitals. So without any kind of substantial intervention to halt that, the number of mergers began to increase. And at the same time, economists started studying the implications of these increasingly present monopolies, duopolies, et cetera. And what they found, of course, was that prices were rising. But even as that became evident, the resources that were devoted to this kind of antitrust work are very expensive and the resources were limited. So hospitals were making a case that they could create economies of scale, that they could create uniform quality standards and provide better value for the dollar under these larger entities. But in fact, there were no significant benefits that we could measure of that kind that ever materialized. In fact, the per capita cost for healthcare in the United States is almost double that of most industrialized countries around the world without clearly discernible better health outcomes. So as the share of GDP devoted to healthcare grew over this period, and the prices for commercial insurance remained unregulated, as opposed to the caps that were put on prices in public programs like Medicare and Medicaid, other kinds of entities like private equity began to identify financial opportunities in the sector, starting with nursing homes and skilled nursing facilities, and then moving on to hospitals and then physician practices. So, this has become big business as the share of GDP devoted to healthcare has increased, and those who were seeking profits saw that there was money to be made here, and so that entry began in earnest and has just grown exponentially over the last 20 years.
Linda, thank you. That's really helpful historical context. Zack, you've been studying this area for quite some time. Would love to hear your thoughts on what's driving these trends and what effect they're having.
Yeah, and thanks everybody for being here, and thanks for having me. Sorry, I sound terrible. I have COVID, so this is like, hopefully it doesn't go through the like webinar portal. Let's take a step back. If the US health system was a country, it would be the third largest country in the world. And so I think it just sort of maybe is important to sort of think about that as we think about what you do going forward, right? You wouldn't have command and control over such a big economy. It's incredibly complex. So why are we seeing some of these transactions? I think it's three things. I think the first, frankly, from the consumer's perspective and from the firm's perspective, the status quo hasn't been working. And so I think you're seeing new and different types of organizations grow. I think we can't be in a position where we say, this is what every organization can look like, because I don't think we know. I think the second is that realistically, scale does matter. I think it matters particularly in a digital world where these fixed costs are going up and up and up. It matters when you ask organizations to take on risk. And I think the third is in a world where prices aren't regulated, bargaining leverage matters. And so you've seen a bit of a horse race between the provider side, and that can include vertical integration and horizontal integration. So hospitals buying each other, hospitals buying physicians, and things on the payer side, where in many ways, even the term payer itself, I think, isn't an apt term anymore, right? These are sort of diversified healthcare conglomerates. And, I think, in terms of M&A, let's just talk about the hospital mergers in particular. Not all of them are bad. So we have some recent work out that says, look, there's probably 50 or so mergers a year. About 25% of them raise prices likely by lessening competition. And so the question is, what's happening to those other 80%? Why are they happening? And do we want to curtail that or let it happen?
Great, thank you, Zach. I'm gonna just do this in alphabetical order, so we'll go next to Steve.
So, and thanks for having me. It's great to see so many folks I've worked with before. I echo a little bit of where Linda was coming from. This has been a long-running trend. I think my first real public policy thing was working in Senator Rockefeller's office in the 90s, looking at antitrust issues, and it still persists to this day. At the end of the day, one of the reasons why I think there's been consolidation is there are additional costs, regulatory costs in different ways, and some of them good, to basically being an advanced healthcare system. So one of the most expensive things that hospitals have been buying, literally taking some cases out bond issues on, is electronic medical records. And that's even with basically high tech and the different legislation back about 15 years ago, basically giving hospitals essentially incentives to buy those systems. It is expensive to be in compliance with HIPAA. It's expensive to be in compliance, to have some interoperability to kind of make things work. It's also expensive to retain talent in a setting where, in many healthcare settings, work-life balance matters, whereas go back 30 years ago, not as much. The workforce has changed. So there's a lot of competing factors as to where things are. I mean, the issue about whether we spend more than other countries, I mean, one thing I always teach in my courses is that, for better or for worse, healthcare's first priority as an industry is monopoly. And for good or bad, monopoly rights give barriers to entry. We celebrate those with patents when it creates innovations for life-saving drugs. But, from licensure for physicians and nurses and insurers on out, we have licensed monopoly all over this market, and we're a wealthy country. To put the two together, no surprise. And the reality is, capital requirements to operate an institution that's not going to be sued for malpractice, not just people, but institutions themselves, requires capital. The private equity markets that are coming in right now are just a new source of capital into a space that people know you're going to get a fairly decent return, because it's a robust market. It's a normal good, and people are willing to pay essentially for living longer and living better as best they can. And they'll do it as long as they can afford to do it. If we were in a different economic situation, I think the nearest country we're talking about, Zach, I think it's France, when you actually talk about the amount of money that's coursing through Medicare and Medicaid. That's the French economy right there. So that, at the same time, with that structure, we have a different level of living. People may not think it's great in terms of some of the concerns we have about it's unequal in many ways, but in general, it's wealthier, and with more wealth comes more consumption. It's that simple. And so for people that are in the private market, they're going after it. And last comment about this, American healthcare is, by its nature, except for government hospitals, entirely corporate. Even Medicare, every single transaction runs through private corporations, has from the get-go of Medicare. Medicare was outsourced originally to Blue Cross Blue Shield, which are still corporations. They may be nonprofit. Half of them are now for-profit. And the one advantage, I suppose, of a for-profit, at least we'll not count private equity here for a second, is that there are shareholders that are looking at the value proposition of what they're getting back. And if they're making a bad deal, they at least have a voice in their shareholder voice to change where that direction is. My concern about private equity is that those shareholders are kind of in the dark. Or at least deliberately in the dark, in the sense of how they're structured, because they're not publicly traded firms. And that might be something we might want to talk about further in terms of quality and controls.
Thanks, Steve. Zirui, you have two hats. You're both a prolific health policy researcher, but also a practitioner. And you see patients, and you are dealing with the financing of healthcare in a very real way. So I'd love to hear your thoughts.
Thank you, Sabrina. It's an honor to be here with my colleagues, Zach, Linda, and Steve. I resonate with all of the economic arguments stated here. I won't repeat those. Simply put, I believe that consolidation was largely driven by the fact that we weren't very consolidated at one point in time, and that the delivery system remains quite fragmented. And thus the opportunities for consolidation arise. And as Zack noted, the price increases are very consistent across many now decades of empirical study. Whether you look at vertical or horizontal consolidation, whether it's physician practices or with larger systems, you're getting somewhere between and even in the private equity literature, between a 10 or 20% price increase quite soon after acquisition on the negotiated commercial rates. On the labor market side, and maybe this is a little bit more clinically relevant, I think that the fact that we have roughly 80% of U.S. physicians in America, U.S. physicians now employed by hospitals and health systems, and the fact that that percentage has grown quite rapidly in just the last decade and a half or so, suggests that there's something about the physician or provider community that is either receptive to or potentially inviting such consolidation. And we should pay attention to that and try to understand it. And so just to potentially provide a little bit of granularity on that front, providers, individual clinicians who own their own practices out in the outpatient world, in the communities, do face lots of challenges and struggles with operating practices, hiring personnel, paying malpractice costs, paying for facilities, and all the physical and infrastructure needs of running a small business in this country, all of which could be offloaded to a larger corporate parent if there is consolidation. That's on top of the market power implications and the price increases. There are also, in many cases, academic privileges that come along to being acquired by a larger health system or academic hospital, which is perhaps non-financial, but quite meaningful for many clinicians. And in today's world of private equity acquisitions, there's quite a generational divide of older physicians who had owned their individual practices receiving quite attractive cash buyouts of their practices from private equity firms that either came to them or that they potentially pursued. There is a bi-directional two-way street here of private equity looking to acquire physicians and practices looking to be acquired or looking for sources of private capital that end up landing with a partnership with private equity. And those relatively attractive buyouts are often not available to the younger generation of clinicians on the front lines, facing the need to generate the revenue to start paying down the debt on the acquisition and the interest on that debt. And so that generational divide in terms of who makes the decisions about these acquisitions is also quite salient. So all the economics are true, but from the clinical perspective, I think for practitioners, there are some appeals to consolidation that we should recognize and understand.
Thank you. I think all of you, in some way or another, have touched on this phenomenon of private equity in the healthcare space. And so I'd love to drill down a little bit further on that. And I'll make this question a jump ball, but I'd love to hear from all of you on it. Why is private equity entering the healthcare space? What is sort of the business model here? Is this a nationwide phenomenon? Is this a specific, Linda mentioned nursing homes. Is just in particular sectors? Is it universal? Like, would love to get sort of a sense of where it's happening, why it's happening, and what it means. Linda?
Yeah. So I think first it's important for us to understand that the way that private equity operates, their kind of modus operandi, is different than other corporate entities. And it's not to say that there aren't issues with consolidation with other types of entities. There are. But if we're focusing on private equity for a minute, we have to remember that private equity, whether it's in healthcare or it's elsewhere, is going to be doing mergers and acquisitions that are heavily debt financed, okay? And the idea is that the gains need to be reasonably short term, right? The idea is, between 3 and 7 years, we're going to gain a profit of 20% on this, and then we're going to get out and move on. Okay, so these are not long-term investors. They're not people saying, listen, we want to invest in, we're medical practitioners, because by and large, they're not. They're lay individuals and entities frequently. They're not people that are looking to invest in communities and build long-term trust and quality care in what they're providing to the consumer. They're going in, they're cutting costs very quickly, whether it's cutting staffing or various other kinds of strategies. Sometimes it's cutting services that are low profit or lower profit services, et cetera. They are then selling off the entities, sometimes in pieces, sometimes in whole, either to other private equity or other investors. But this is an approach to investment that is consistent with the way that they invest in other types of companies, et cetera. So there is, the idea is, why is private equity coming in here? Well, it's as Willie Sutton said, it's where the money is, right? So it makes it clear why they're coming in there, as we were talking about the size of this sector. But at the same time, these are very different kinds of investors than we had traditionally seen in the medical care space. And that's also why it's raising so many concerns and red flags, is because these are not entities that are necessarily concerned with investing in the development of high quality care. And while there are some real returns, as Zirui was saying, with regard to some of the providers, and that those providers have had pressures from COVID and the great complexity of the billing systems that we have in commercial insurance and how hard that is for providers to deal with individually. The outcomes that we're seeing are not necessarily, in many ways, they're not consistent with what we'd hope from, those who are really interested in building value in the medical care space.
So I'm going to jump in quick, and one, just to say that I'm sad that I couldn't use my Willie Sutton reference that I was pining to use, Linda. But I'm going to get over that pretty quickly. But I want to turn this around a slightly different, because I thought about this for a while, and the question, and actually I really liked when I teach my healthcare markets class, I usually like to do like 100-year history, like how did we even get to this market? And a lot of it is about monopoly behavior and things like that. Question I have is, like, why has private equity been successful in this space? If you think about it, hospitals and physicians, built an enormous monopoly power structure and corporate structures. I mean, I think all of us read at some point in our lives Paul Starr's Social Transformation of American Medicine. If you haven't, it's in its 3rd edition. Only read book 1. Book 2 is about the 80s and kind of weird. But I mean, but it talks a lot about when people say the healthcare system's broken, my refrain is like, no, it's the product of essentially really smart, clever people over the course of 100 years, most of whom are dead, but their legislative and policy initiatives outlasted them, and they conflict with each other because they're not necessarily consistent. A policy in the 1940s doesn't necessarily conform to a policy in the 1970s, et cetera, et cetera. But I mean, to the issue of the serious point about, like, there's people are they want to get out and they want to sell their practices. I remember when this was practices were being bought in the 90s, in that period, they were being bought for about 5 times the price of what they're being bought for now, which means that the economic power of the providers is much less, which is why they're accepting private equity. I guess the question is, if they're in a weakened state, why are they in a weakened state? Because as Zack's research has shown, prices keep going up. They should be doing better if their prices are beating CPI. So if they're in such a fragile state, is it because they just don't care anymore and they want to actually be subjected to the things that Linda's talking about in terms of 20%, gain based on slashing costs and quick returns and being cut up? Or is that they just don't have the economic heft anymore to self-power themselves as independent monopolies in a closed trading system? I mean, that's the thing that's bothering me, because if that's the case, then we are in a much more fragile system than we might expect.
Zirui, I see you nodding there. Do you have thoughts on Steve's question?
Yeah, let me just ask, Zach, do you want to go first? I'm happy to go.
No, please.
Okay. I think that when we think about the private equity business model, and this applies also in part to Leah's question and Gary's comment in the chat, there seems to be a set of distinct differences between extractive models of acquisition, where healthcare entities, whether hospitals, nursing homes, or practices, are used as vehicles for short-term returns, and growth types of acquisition, where it is much more akin to a venture capital or growth equity type of investment. They can all fall under the broad roof of private equity, but private equity investments are indeed not monolithic. And I think it is helpful to figure out, especially from a policy lever perspective and from a community perspective, which type of acquisition are you considering or evaluating? So in the first category of extractive types of acquisitions, often we've learned that these are leveraged buyouts using large proportions of debt in the acquisition price to buy big brick and mortar places, after which the assets are slowly sold off, sometimes quickly after acquisition, in terms of land and buildings being sold off to a separate real estate investment trust, in terms of cuts in staffing, cuts in supplies, and cuts in the cost of delivering care, and in terms of selling off the value piece by piece in return for dividends, the so-called dividend recapitalization approach earlier on after acquisition, for quite immediate returns to one's investors. Those types of practices, sometimes bucketed in this phrase asset stripping or cost cutting more broadly, render the acquired entity simply a short-term vehicle for generating profits quickly. If profits are the prices of the things you do, multiplied by how many things you do, minus the cost of doing those things, the three basic levers for generating profits quickly are increase your prices, increase the number of things you do, the number of patients you see, or cut the cost of delivering care. Turns out that cutting those costs is sometimes the fastest thing you could do. And we've seen across hospitals cost cutting to be quite pervasive, on the order of about 15, 20% of salary expenditures, for example, with some of the working studies. And so that type of extractive model seems quite different than many private equity acquisitions, including physician practices or certain specialties like behavioral health, cardiology, and some other examples where there are investments in a new idea or a new way of delivering care, or indeed, perhaps improving the efficiency of care delivery. And often the private equity dollars initially do come in with good intentions of improving the care delivery, but there still needs to be the profit that comes out of that investment. There's still some short-term pressure to generate that, though not always as short as the extractive model, or 3 to 7 years. And often those acquisitions are then acquired in that sale to a second, acquired by a second corporate owner, who then may not see that acquisition in as unique of a light. Instead of a new innovation that you're really investing in and growing and you want it to succeed in the long run, now it just becomes another item in your portfolio of things that you've bought, successful things that you've bought. Now, when that happens, what do we think about the private equity investment at that point? Right? It helped something grow, but then that thing got bought. Now, you could change your normative view of that based on what the second owner does. The second owner is often another private equity firm, but sometimes a larger corporate firm, sometimes an insurer. But these seem quite different from the extractive model. So I think if our target or our focus of policy is on the extractive side of things, there's a lot of work to do. There are over 450 hospitals, over hundreds of nursing homes, now hospices as well, and indeed thousands of physician practices that have all taken on versions of debt with short-term returns as a focus. And I think distinguishing that from the more growth types of investments is quite important. But ultimately, what you said, Linda, the concerns for the community, the concerns for patient well-being, concerns for policymakers are certainly very salient, given what we've seen with increased mortality, increased patient harm, higher prices paid by employers, insurers, and society as a whole, taxpayers included. So despite there being this nuance and heterogeneity, the overall concerns, I think, are still quite valid for policy.
Yeah, I mean, I think, so I actually think the variation is tremendously important. And, I'm not, personally, I don't think the distinction between nonprofit, for-profit, and private equity is actually that significant. I think the sort of variation within each of those types swamps the variation across the types. And we have some interesting work coming out on that. I think if you talk to folks in private equity, they sort of all know actually who the bad actors are, and with a remarkable degree of consistency. They'll all sort of point to firm X as saying, oh, okay, those are the folks doing things that maybe got to be worried about. Two other sort of thoughts, and it builds off what Steve's talked about. He's done a great job of really sort of zeroing in on first principles. And I think there's a couple issues here. One is I think private equity in some ways is it's a symptom, not a problem itself. There are lots of ways to make money in healthcare that are easier than delivering better value and better patient care. And those are functions, quirks of government policy. They're sort of idiosyncrasies in how the market functions, and it shouldn't be terribly surprising that aggressive capital flows in there. So that's a sort of first. The second is I think it should force us to ask some very, very real questions. And again, it's getting back to the status quo. If there's a company, whether it's private equity or not, that buys a hospital and is able to sell the land and make a profit, it does raise, and this is sort of why people don't like economists, like why the hospital is maybe there to begin with, right? If the opportunity costs, I make it up, putting in a big box store had bigger economic returns, okay, should that hospital have been there? I think the honest truth is if we asked most of the leaders in healthcare whether there were too many hospitals in the US right now, or that some of these very, very small places probably weren't delivering the best care, I think you get a lot of people who said yes. And it's just very hard to talk about that. And that gets to I think the third, or maybe my third point, but I think we should be talking about private equity. I've been on a lot of sort of panels like this. And I think one of the things that's tough is it's easier to talk about private equity than it is to talk about some of the big macro problems in healthcare. So a lot of the conversations about healthcare policy and why we spend a lot shift to private equity and PBMs very, very quickly. And they sort of ignore market power, these sort of big tectonic plates that are shifting that Steve has raised. And I think unless we really engage fundamentally with those, we're going to be in trouble. Framed differently, you could get rid of every private equity firm in the US, and the US health system is going to be way more inefficient and still way higher priced than any other system in the country or in the world.
Thanks. I want to make sure we have plenty of time for questions. So I'm going to ask you guys one last question and ask you to sort of very briefly share. We have a number of folks who are policymakers or policy adjacent in the audience here. Elected officials are witnessing what's happening in their own markets. What's for each of you, what is your one, and just you only get one, but what's your one piece of advice for policymakers about how they can learn more, what they can do, how they can respond? So we'll start with you, Zirui.
Well, the challenge for many of our colleagues in state government in particular is simply to understand the scope of the acquisitions to begin with. That is, who bought whom, where, and when. There's not enough transparency there for public officials to even understand who is susceptible to these financial incentives and where potential attention should be paid. Though I think that the harder work begins after transparency. I think that solutions are incredibly difficult because to really have regulatory teeth behind the financial incentives that govern, as Zack said, that fuel much of these acquisition activity, you'd have to get into the use of the debt. You have to get into the dividend recapitalizations. You have to get into the use of the lender, the bank. You have to get into the ways that the fees are processed from the investors to the parent private equity firm and from the acquired entity back to the firm. And there is an intrinsic difficulty in regulating this type of free market activity when the healthcare system, by and large, remains largely a free market that is free from most types of regulation, although obviously we have regulation. And so the fundamental challenge is how do state and also federal policymakers pierce the veil of the private market that we in many ways allow its freedoms, but also to do so in a targeted, thoughtful, regulatory manner that protects patient well-being, clinician well-being, and societal resources. There are many things that policymakers may want to go after that simply we don't have the policy levers to do. Many of these transactions are by definition private. These are private dollars buying private entities on their own privately negotiated terms. And we simply do not have many public policy levers to get into these private transactions. And if we did, if state lawmakers or at the federal level wanted to build some of these levers, I think you can quickly see that indeed patient well-being and clinician well-being is often put at risk when you allow staffing ratios or cuts in staffing to affect frontline care delivery. If perhaps we can all agree on, depending on our view of economics and free markets here, it's something different about healthcare with respect relative to manufacturing other types of products is that we remain a largely effort-intensive human endeavor, where so much of the care, especially in facilities, is person to person, face to face, where you need all hands on deck. And indeed, there's some inefficiency there that could be cut. But when you start cutting the hands on deck, you very quickly get into scenarios where the bandwidth to deliver care and respond to patient needs decreases, and your ability to respond slows, and patients then face the risk of being harmed. And I think that is why the classic strategies of cost cutting run very quickly into patient outcomes in healthcare, whereas making toys or other consumer products may not face that so immediately.
Okay, we're gonna ask our panelists to be brief because we want to make sure we're getting to our Q&A. Steve, briefly, your one piece of advice.
Sure, and I'm going to deal with data that's already out there that I think FTC and DOJ can use. So the price transparency stuff that started with Trump and then continued from Biden, a lot of work I've done in the space. Basically, that data is huge and should be harvested. I'm working on it to harvest it and get it out in the public domain, and DOJ and FTC should use it. One of the things I insisted on when I was working in the White House in the Trump administration was that the data gets released monthly by the insurers to track monopolistic behavior, collusive behavior, things that basically qualify as per se violations of antitrust. If you're concerned that these institutions are basically manipulating and pushing up costs prohibitively high for no additional value, harvest that data, use that data, put out a status report, and tie it back to outcomes as best you can determine them from the sources that are there.
Thank you. Zack.
Yeah, I'm going to give two. Sorry. I think there's some tweaks to that data that need to be made that need to make it work well, and I would invest a lot in that. I think the second is really consistent with Steve, much more antitrust enforcement, and that really comes to funding to the agencies. Right now, they are chronically underfunded. Hospitals are 6% of GDP. A year of increases in prices from hospital mergers trumps the budget of the agencies. That you get what you pay for.
Right, Linda.
And to not repeat what anybody else has said, I'll just say I would caution policymakers to understand that looking at right now, we're treating these markets, whether it's the providers and the ownership and the mergers and acquisitions, the insurers, the interaction between the two, sometimes the one's a wholly owned subsidiary of another, all of the intermediaries that are profiting off of all of the interactions that are so complex. Our lack of oversight and regulation is almost like a presumption that these markets are competitive, and they are anything but competitive at this point. And we can do more antitrust work and put more resources there, which I wholly support. However, that train has left the station, right? There is so much consolidation, and it seems much harder in this country to undo a consolidated entity than to prevent it from getting there. And so, I think what we need to be thinking about is what are the appropriate policy levers when you have a critical industry to the well-being of every American, and it is completely non-competitive. And now, all of the pricing and the interactions between all these entities is there's very little oversight and very little regulation of it.
Thank you. All right, we're going to turn now to questions. We have several that have been submitted into the Q&A box. And just a reminder, if you have a question, please put it in the Q&A box so that we can see it. So the first question is, more and more states are adding some types of transaction review with varying degrees of teeth. Do any of you think this will slow some of the M&A activity? I see Zach, I see you nodding.
Yeah, I mean, so I think I'll give you the upside and the downside. So let's just give the best example. Indiana lawmakers there recently blocked a really bad merger in Terre Haute. It was a merger opposed by the Federal Trade Commission and opposed by the governor there. Governor there is pretty conservative. The FTC chairwoman at the time was decidedly not very conservative. They both agreed. I think states can do that, and they can make up for some of the shortfalls that happen with the federal government. Here's the risk. It's political capture. And I think one of the challenges you get when states get deeply involved is some of the incumbents can use some of these merger reviews as tools to weaken their allies instead of make markets competitive. So if they're doing good analysis, I think this can be a very effective vehicle.
Great. The next question is, and I think we've touched on this a little bit, but if anybody wants to expand, who are the losers in all of this consolidation? Steve, you just came off mute.
Yeah, I'll just go. I mean, communities are going to be losers if you cut these things up too badly. I mean, that's the only issue. If you're going to be liquidating community hospitals, that, I mean, be fair, if they're poor quality, they deserve to be liquidated. But if they're basically serving a critical function and they're just undercapitalized and not able to do things, and I'm thinking more rural hospitals you get for out of the Mountain West and other areas. I mean, you really have some situations now where you have to go a long ways to get access to decent care, and to the extent that is being driven by this and stuff being cut up, that's a major problem.
To Robert's question about who pays for it, we have a paper that came out a couple months ago, who pays for rising healthcare prices, and we track it through labor markets. It's basically people outside the healthcare sector. It's concentrated among workers earning $20,000 to $80,000 a year. How are they paying for it? They're losing their job, unfortunately. The really challenging part of what we show is losing your job, as we all know, is terrible. And so we actually see that folks in areas when hospital mergers happen that raise prices lose their job, and then a small chunk of them die from overdoses. So I think it's reverberating. It's sort of this silent driver of inequality and economic dislocation across towns and cities in the U.S.
Okay, well, this is maybe the next question is really right on point, and I think Zirui, you touched on this one. This audience member says that her local hospital is a rural hospital that's failing financially. The only organization interested in acquiring it is a private equity-backed company. Community is very concerned. The question is private equity the monster that we see it as? Is there any way this could turn out well for our community?
Yeah, thank you. We see this a lot in anecdotal, compelling stories in many communities. The reality is that many hospitals and nursing homes and other facilities do need additional capital, whether to hire people or to buy infrastructural improvements. And when you look for those additional dollars from the fee schedule, unfortunately, the Medicare fee schedule, especially the conversion factor and the payment rates, have not grown for quite a long time. That's not a source of that capital. The Medicaid fee schedule or capitated payments in the private Medicaid plans typically not a source for that type of capital. Negotiating for higher prices from commercial insurers is a potential avenue, but left on your own, a small rural hospital doesn't have the market power to do that either, although on average, rural hospitals do have more market power than urban hospitals that face some competition. And so ultimately, if these payers are not the sources of additional capital, indeed, private sources of capital become more attractive, almost by the process of elimination. And so it places these targeted entities in a really precarious state. Some of our recent work showed that rather than private equity firms targeting financially distressed hospitals, which is often the rationale that is presented, which does happen in some cases, that is certainly true in instances. On average, however, private capital tends to target more financially healthy hospitals. Why is that? You're going to place immediately new debt onto these acquired entities. It makes much more sense to put new debt onto a financially healthier hospital that could take on that debt and still generate revenue for you, as opposed to a financially less healthy hospital that may more easily crumble under new debt. So we know that the targeting is not random. and the entities targeted often need the capital. So to Leah's question, what can they do? It is an incredibly difficult position to be in when your alternative is no capital walking through the door, or this type of capital that comes in with all sorts of strings attached, full or majority ownership, decision-making authority, ability to cut staff, sell the land in the buildings and walk away. You know, the prospect of that is quite scary, especially for community access. So guardrails are probably where policymakers, going back to your previous question, should go in assisting these communities. What are these types of guardrails? I mean, there are examples that we don't have time for, but making sure that the investments are not extractive, at least not in the very short term. Making sure that the percent ownership can be something that allows clinical decision-making authority to still rest with the clinicians, as opposed to the corporate owners often many miles away. Making sure that there are safeguards for potentially government intervention or policy protections, making sure that staff to patient ratios are protected at some baseline amount. And these are things that you could think through as you write a contract. We don't have systematic evidence that this works or is even feasible. But if you look at one outlier example, which is ironically the National Football League, the NFL for the first time allowed private equity investments this past August in 2024. They put up a host of guardrails and safeguards, not allowing private equity firms to get majority ownership, giving private equity firms zero decision-making authority, making sure that private equity investments are fully disclosed to all the other teams and the league, making sure that the percent ownership is dictated, fully capped, even if multiple parties invest. You're capped at most 10% of a team, and various other protections that we just don't have in healthcare. And that's just one type of an example of a set of guardrails. And I think policymakers, to Leah's question, could help community hospitals move more in that direction.
Okay. This is a great question. You focused entirely on provider consolidation. Why are you not talking about the massive consolidation of insurance companies? Anybody want to field that one? Linda.
So yeah, no, I mean, that's the conversation went that way, but I don't think any of us is ignorant of the situation that the consolidation is going on across the board in healthcare, right? And so you've got not just the consolidation of these large healthcare systems, you've got insurer consolidation, you've got insurers and providers, merging with each other. You've got all kinds of contracts that each of these players is taking on, sometimes with wholly owned subsidiaries, to do kind of endless rounds of claims adjudication that is increasing and creating fees, generating fees on both the insurer side and on the provider side. And so, yeah, no, all of this is integrated together. And and I think maybe it was Zack who said in the beginning that we're no longer talking about these individual entities and players of payers versus providers, because the crossover in terms of the corporatization has just made it so that these entities are so large and multifaceted that it's almost impossible sometimes to pull apart all of the pieces to see exactly where the flow of money is and who's making how much on what piece, because they're all integrated to a really complicated degree.
Yeah, one of the stats I that always strikes me is that United Healthcare, which many of us think of as a quote unquote payer, is now the largest owner of employer of physicians. Yeah.
Public policy matters profoundly, right? So there were some really big managed care deals proposed in the sort of 2015 area, Aetna, Humana, Anthem, Cigna, and both got rejected, right? They got blocked. And I think that was a very, very clear statement from policymakers and the judiciary, like, no mas, right? We're really not going to allow those sorts of transactions. And what it did is it opened the door to vertical deals. And I think there's two things to keep in mind. One is the theory is just a whole lot more complex. Like, I think it's just much more nuanced than horizontal cases. And I think we just have to sort of approach some of them with humility. I don't think we know exactly what the effects of some of these will be. I think we have to investigate it. I think we have to look at it. I think the final one is the sort of real, the one vertical integration thing that really worries me is the payers and the PBMs. I think that one we've sort of broken that market, probably irrevocably so. And so if there's one sort of chunk there that I'd really focus on, that's probably it.
Yeah.
Okay, well,
But I
sorry,
just
go
want to
ahead,
echo that.
Steve.
Just want to echo that just for the policymakers. I mean, that is the market that needs some looking into. I mean, I remember I used to work for the insurance industries, and I understand PBMs did a great service because, let's face it, the old school insurance companies didn't understand pharmaceuticals to that level and all the things that were possible with different pricing structures. And they worked for that, but that is not the value prop they're giving today. They need to be it will be a rules or reg change to basically set that boat right that Zach's talking about, but it definitely needs to look, because right now it's inefficient the way it's operating. It is probably the biggest cost of deadweight loss that exists in the market today.
All right. We have a question. It says policymakers in some states are talking about ways to ban private equity. Given the discussion about variation in behavior in private equity, the audience member wants to know, can you comment on the feasibility and limitations of a ban, and how it might compare to other options like transaction oversight?
My very brief response is that banning appears to be either impractical or simply not feasible in many states, and that market oversight, where many states have started, seems to be the reasonable place to go. Banning it's also not very specific or nuanced, and as we were discussing, it is not a monolithic type of investment.
And just to complement what Zirui saying, the states have licensure rights when they're talking about providers and or the insurers that are much more binding than what the feds can do. Whereas like what happens when private equity can basically be state to state, interstate commerce in terms of how all the structures, the states are going to be the best way to put the guardrails up to more or less. For example, the Zirui mentioned staffing ratios. Those are governed by states more often than anything else. And that could be a very powerful piece when you're worried about, something holding out the labor supply of a hospital unnecessarily.
Great. Question, what are the best resources or information to use for public education on quality of care reduction as a result of healthcare consolidation? I know, some of you have looked at what happens after a merger or acquisition to patient care.
Yeah, I mean, there are some good literature reviews out there. If you go to our 1% Steps for Health Reform project website, we have a good synthesis document. I think overall the sort of evidence is with mergers, quality sort of largely doesn't change. If anything, maybe ticks down. I don't think there's great evidence showing that it gets worse. There's a lot of good evidence showing that hospitals that face more competition have better outcomes.
I personally would just like to see more outcome measures that are generated by the research community, or at least in combination with industry. We have had now literally billions of dollars, hundreds of billions of dollars invested in electronic medical records, and yet we as researchers don't harvest that data in a systematic way, the way we've used claims data for the better part of 30 years. Even if there's just a synthetic, PHI neutral database for us to invent new metrics, that would be helpful. Otherwise, readmission rates, 30 days, hospital immortality, and like a handful of other measures is insufficient to systematically measure quality in a multi-trillion-dollar healthcare system. It's ridiculous.
I agree.
And I'd say on the private equity side, there's quite a good and increasing in size literature that shows decreases in quality of care with most PE acquisitions. Not always the truth, but with a lion's share of it, particularly in hospitals. The data and so the methods that we have for going and looking at this carefully in physician practices is a lot less robust. And so we get, some kind of equivocal, types of results, but the measures of quality, I think as Steve was getting to, are really very squishy, very limited. And so we've got a long way to go there. But I think at least on the PE side, the quality measures on hospital outcomes are getting more and more robust, and there's been more studies out there that are showing significant decreases.
Right. Well, we're going to have to call it there because in this webinar series, we promised folks a few minutes to get to their next meetings. So I want to thank Linda, Zack, Stephen, and Zirui. We could not have had this conversation without your wisdom and expertise. And I want to thank all of you for being with us today. I hope you will join us for our next webinar on February 28th, where we will focus on solutions and talk about what policymakers can do to rein in some of the more harmful corporate practices and trends that we discussed today. You can register for that webinar now. We have dropped that link into the chat, and we will send it around with today's recording too. So please sign up and tell your friends. Finally, we're going to ask you all to please fill out the very, very short survey that's going to pop up on your screen once you leave this webinar. Your feedback really does help us in designing our events. Thank you. Happy Valentine's Day, and be well.